Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all the ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in to the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare technology. I'm very pleased today. My guest is Dr. Stephen Lane, the Chief Medical Officer of Health Gorilla. Health Gorilla is an interoperability platform that provides permitted access to actionable patient data. Customers use Health Gorilla to improve outcomes, streamline workflows, and create a more equitable ecosystem. Dr. Lane, welcome to the Tate Chronicles.
Thank you, Jim. It's a pleasure to be here.
Today's topic is interoperability in general and specifically TEFCA. Last week, we're recording this on February 22nd, but last week, Health Gorilla was one of the 6 entities whose TEFCA QHIN applications received approval last week to proceed with the testing process that, if successful, will lead to being designated a Qualified Health Information Network. The plan is, and it's always a plan until it comes to fruition, is the networks will interact with each other to create a network of networks. So my first question is kind of a general one, but I'm just curious, what was the application process like to receive QHIN approval during the testing process? How long does that take? How complicated was that?
I mean, it's taken a number of months. The application details were initially published by the RCE, the recognized coordinating entity that is working with the Office of the National Coordinator to stand up and operationalize TEFCA. So as the details came out, and I don't have the dates in front of me, but they were published typically in draft form. There was a public comment period, so everybody who was interested in participating had a chance to see what direction this was going in, and then the final application and requirements, technical requirements, all came out publicly, and there was a months-long process of submitting the application. For most of the entities that were applying, this was really all new in the sense of some of the new requirements, specifically the high trust certification. In fact, I'm not sure if any of the 6 actually had that before this process started, but I think part of the substance of TEFCA is that it does raise that bar, especially for technical security and the use of specific technical standards on the part of the QHINs as they manage their QHIN to QHIN exchange. The system does leave a lot of flexibility for how the QHINs will be interacting with their participants and their sub-participants. There are flow-down provisions that must be satisfied contractually. But in terms of the technological and the security structure in this initial iteration, it's really been focused on protecting the exchange between the QHINs themselves, who will be that network effect that allows everybody to connect over time.
Well, I know one thing that, of course, TEFCA planning and work has been going on for 6 years.
It has, yeah. And it's been fun because I've had a ringside seat to that whole thing. I've served on the ONC's Health IT Advisory Committee since it was launched a little over 6 years ago, really right after the 21st Century Cures Act was finalized and they started operationalizing that. So it's been amazing to be in DC, part of that ONC process as the first versions and the subsequent versions of TEFCA came out. We had a number of work groups and task forces that dug into those, made suggestions, had some impact on the final version. And then also I work with the Sequoia Project as well as Cara Quality, who serve as the RCE and the team that are operationalizing this. So I've seen it from every angle here over the course of this process, And now, very excited to be at Health Gorilla, where we're actually going to have the chance to operationalize this as a QHIN, as you say, presuming the testing goes well and the final designation comes through.
And I know that the 6 entities that have received approval to move forward in their testing have all committed to going live within 12 months. So that's sounds like sometime before the end of the year, there'll be at least 2 of the QHINs out there, because you need at least 2 to exchange the data. So
well, I can add a little bit to that. So
right.
the 12-month number really comes from the TEFCA framework itself.
Mm-hmm.
So that was part of the application process. As they said, once your application is accepted, you then agree to embark on testing and to go live within 12 months. But of course, 12 months from February is February next year.
Mm-hmm.
But when we were in DC last week, we all stood up on stage and agreed that all of the 6 entities were committed to going live this calendar year. So that ratchets it down by a couple of months.
Yeah.
We were on a call with the RCE, that was yesterday morning, where it was clarified. There was a comment made, in the DC meetings about how many QHINs would it take for us to really go live, and it was clarified yesterday that they're really looking for at least 3 of the QHIN candidates to be ready to go live before we flip the switch and start to move data. So I knowing all of the QHIN candidates quite well, being formally engaged with a number of them, I think there's a very good chance that we'll have at least 3 ready to go this calendar year, and maybe all 6.
Well,
and maybe more. That's the other thing, is that the QHIN application process remains open, and other entities, are welcomed to come forward with their applications. So any day we might hear about, additional entities that will enter the fray.
Now, the requirements are so precise and so high that I would be surprised to see a startup with no prior experience in data exchange jumping in.
Well, not only surprised, it would not meet the criteria. I mean, the requirements do specify a duration of functional production exchange and a volume of such exchange. So you really can't just come out of the woodwork and do this. You have to be an established health information network that's been exchanging data for some time.
Well, and that's a good segue. I've certainly heard about Health Gorilla for quite some time. How long has Health Gorilla been in business, and how long have you been exchanging data, and what kind of data have you been exchanging?
So, I'm relatively new here, but Health Gorilla has been in business for over 8 years. It started as a lab network supporting the exchange of laboratory orders and results for practicing clinicians, mostly in small office practice that didn't enjoy the benefits of large health system connectivity that was, pretty well established by that time. And then over time, they transitioned and expanded into doing full document exchanging the continuity of care documents that really make up the vast majority of interoperability of health data today. And they've been doing that now for a number of years for a growing group of network participants. A lot of those participants are clinicians in either, as I said, the small office space or now the new digital health providers who are really coming, into the healthcare ecosystem, whether we're talking about telehealth or fully online services, where these providers need to access clinical data in order to provide their service, and then they need to make the data that they generate available to other members of a patient's care team. So this need for interoperability has expanded beyond the kind of the traditional brick and mortar practices that have had this for some time. The other thing, of course, is that physicians in hospital and office-based practice, for the most part now are utilizing certified health IT or certified electronic health records, which have had built into them the technical capabilities to do this kind of exchange, whether it's via query-based document exchange or direct messaging. All of that has been baked into the certification standards for EHRs. But a lot of these newer entrants, the telehealth, the digital health, those folks are often using homegrown electronic medical record systems. So they are not necessarily certified to the ONC standards. So they haven't had that head start of building in that interoperability solution. So a company like Health Gorilla can come to them and really provide an interoperability solution set that allows them to enjoy the same kinds of data access. And then the other thing that Health Gorilla did, I think, fairly early on was they decided that they were also going to serve in the role of a private health information exchange. That is to say, aggregating the data from their network participants, putting that together into more of a longitudinal health record so that when clinicians access that data, especially those who may not have a fully functional EHR, or even if they do, just bringing all the data from the various sources together into a longitudinal view, and then working towards really optimizing that data, fleshing it out with additional data sources, improving the data quality, making sure that data is appropriately mapped to standards such that it can really support the semantic interoperability that we all need and want. So, and then I've been here, as I said, for about 5 months now, and we've already, just during that time, seen additional data sources and data types coming into the platform. So a real push to bring in social determinants of health data, which is obviously a very important source and type of data to support health equity, recently launching a new source of medication dispense data from pharmacies, from a big network of pharmacies through a partnership with Dr. First. So there's this intention to continue to expand the types of data, sources of data that are going to be available. So we're building out a more and more robust and comprehensive view of any given individual. And then over time, as we now proceed down the path of TEFCA, we'll see these increasing use cases, starting with the treatment and individual access services, and then moving on into payment, healthcare operations, public benefits determination, public health exchange, all of the use cases that have been identified to be part of TEFCA over time.
Let's talk about you for just a minute. As a physician with over 30 years of medical practice, what has been the nature of your medical practice?
Well, I've been a primary care family physician since I went into practice in the late 80s. And I, along the way, spent some time as an emergency physician, did a lot of public health work, and was in academia for a number of years, but actually came to my current practice over 30 years ago now, where I've been providing, lifelong care for multi-generational families in the primary care setting. And that's very much informed my view of the importance of health data, the utility of health data, and the importance of exchanging that data to provide optimal care for patients.
Well, and that's why I asked, because 30 years ago, the ability to get health data, well, actually, the first big step forward was when they unboxed fax machines and plugged them in. Before that, there was just, unless somebody had the information, if they were a new patient to you, if they weren't carrying it in a little folder, you weren't going to get any.
No, you're absolutely right. Yeah, so my first exposure to health information technology was in 1989 when I was, working in the emergency room in a hospital in San Francisco, where some of the docs had brought in their Macintosh computers, those boxy things that used to sit on our desks, and they hooked them together with little Ethernet cables, and we put together an EMR just for the docs in the emergency department. And it immediately showed me how powerful this was, the idea that you could find the chart, that you could read the chart, that you could read other people's notes, that we could start to bring things together. So after that experience, I spent, the 1990s really working towards, the implementation of more comprehensive and modern day electronic health records, and, did that in the late 90s and then moved on, to the optimization and use and extension of that. So, what we saw come out of the High-Tech Act and the incentives on the part of the federal government to push forward the digitization of healthcare really grew out of those early decades of experience of just trying to hack it together.
I'd like to mention to our audience, if you're just joining this episode, I'm Jim Tate, and on today's version of the Tate Chronicles, I'm speaking with Dr. Stephen Lane, Chief Medical Officer of Health Gorilla, and the topic is interoperability and TEFCA. I was listening pretty carefully last week, Dr. Lane, during the QHIN announcement. I'm going to give you a quote you said, and we're going to talk about it. Because I've found out that whereas all QHINs will meet a certain standard, some will go beyond that standard. So let me read your quote. So that's one way in which the QHINs will be very unequal. Some are proudly passed through, and others are firmly committed to enriching the data. And so what type of value add does healthcare intend to bring to TEFCA?
Well, as you mentioned in that quote, there are some QHINs that are going to primarily focus on moving data from point A to point B. And doing that with a high degree of security, but it's really a pass through, and that's an incredibly valuable service. If you have a robust EMR on one side and another system on the other side, and they just need to exchange data. That's really what we are doing today in a lot of health information network functions. And a number of the QN candidates have really honed that skill and are going to carry that forward from today's framework that we manage under care quality to the future framework that we'll be managing under TEFCA. What we typically refer to them as health information exchanges or health information organizations. Those are organizations that specifically bring together the data from multiple sources and try to weave together this longitudinal record of more comprehensive data. So they're not just moving it from point A to point B. So that's what Health Gorilla as a private HIE endeavors to do, is to bring that data together, as we said, from multiple sources, and give that comprehensive, so both deep and longitudinal, broad view of an individual's data. And again, over time, I think we'll see this also being applied to population health management. The more data that you have on an individual or a population, the more intelligently you can make decisions, the more safely you can deliver care, the more you can predict what may happen in the future in terms of readmissions, in terms of drug interactions. I mean, you name it. So I think there is real value in aggregating health data. And I think that, as I said, is going to be one of the first and largest differentiators. There is, some, I think on both sides of that dichotomy, there are people who really feel like, what they're offering is terrific. And I love that, because
Sure.
You're going to have entities that really do everything they can to optimize the model that they are pursuing and the product or service that they're delivering, which is going to give us, I hope, a diverse ecosystem that will support all of the different use cases and participants that we're going to see coming on board as TEFCA rolls out.
Well, that is one of the issues I think we may well see. Some QHINs may, for lack of a better term, enrich that data. And by that, I mean strip out duplications and do things like that. And there may be third parties that are participants who are connected to QHIN. They may take that QHIN data and then enrich it themselves before they pass it on. It's going to be fascinating to see how this all comes together. One thing that I think is a good idea, was really necessary, is that TEFCA had to be backwardly compatible so that all the existing HIEs and related healthcare exchanges out there would not be mothballed as soon as TEFCA goes live. And so that kind of brings me to a question. If in 3 years, if I was a provider and I was in a patient's chart and I'm hooked up to a QHIN and I hit the button and request and send an inquiry and receive data back on a patient, unless that data is it really just going to be CCDA files? Is that what's going to be coming down the pipeline? If it
No,
hasn't, yeah. Mm-hmm.
no, I think the plan, there is a very clear FHIR roadmap that
Right.
has been laid out by the RCE, and it's got about a 3-year time frame
Mm-hmm.
where we are going to be advancing from, using the QHINs to simply facilitate FHIR connections to really using FHIR to move the data across the QHIN framework. So I think that, there, again, the vast majority of the exchange that happens today, certainly for treatment purposes, does leverage the clinical document architecture, the CDA standard,
Mm-hmm.
and specifically that one particular document type that you mentioned, the continuity of care document, the CCD. But there are many document types, that are
Mm-hmm.
used for many specialized purposes where you can be more specific in the data that's being sent, either at the encounter level or for a specific use case like electronic case reporting. So I think document-based exchange will persist for the foreseeable future because it really has been optimized for a number of good use cases. But I think as we see TEFCA rollout, as we see the FHIR roadmap go from optional to required for TEFCA exchange, we're going to see, and as we see other changes in our ecosystem, the CMS rules for payer data exchange, all of the work that's being done by the Karen Alliance to support individual access services in the current framework, I think all of this is going to converge under TEFCA. And I think, the point that you made about backward compatibility is really important. It's an interesting way to phrase it. The way that I think about it is, there is a whole community out there, a number of communities that have been advancing interoperability, as we said, for 20 plus years. And many of those people have invested in specific technological solutions. They build businesses and business models and whatnot. Some of those have been very fruitful. Some of them are sort of a drag on the system, and they kind of get in the way of us being able to move data more efficiently. But I think, to me, TEFCA is, I like to use the umbrella metaphor because the RCE and the ONC have used that in so many of their graphics, but that there's room under the umbrella for everyone. And even though there are communities that are utilizing technical standards, for example, that were not named in this first version of TEFCA, that doesn't mean that they're not meeting an important need, in the healthcare community, and couldn't, come into the TEFCA framework. So I really see this as a growing collection of participants, of use cases, of data classes, as this moves forward. But it's right, you're right, that the backward compatibility, we don't want to lose access to the data that we have access to today. I mean, in truth, most healthcare is carried out based on fairly recent data, right? You want to know what's your current medication list, but you also want to know what kind of a reaction you had to a medication 15 years ago that we shouldn't give to you again.
Correct.
So, and there's a lot of care gaps, colonoscopies. A lot of people only get them every 10 years, right? I mean, so you need to have that view into the historical data. I mean, really, we've only been collecting health data electronically since the 1980s, right? I mean, before that, everything was on paper, spreadsheets were on paper. But we need, in my opinion, to look back that far. The way I like to refer to it is you want all the data from lust to dust. You need to know what happened before conception,
Yes.
during pregnancy, all of pediatrics, adolescence, adulthood, all the way down. And I think that, to me, that's the scope of data that we're after.
I think that's probably a pretty good place with that quote in things. But before we say goodbye, for our listeners who want to hear more about Health Gorilla and Health Gorilla's work and services, where should they go to find out more?
Well, we've got a robust website where I think one can submit questions and get contact information, and I'm sure our team would be happy to connect folks up with the right resources, including me, if I can be of benefit.
And that's at healthgorilla.com. We know a couple of big conferences are coming up at we're recording this in February. I know at the end of March, the large VIVE conference is in Nashville, and then annual HIMSS conference is in Chicago in April this year. And I'm betting Health Gorilla is going to be at both of those conferences.
You would be betting on a winner there. Yes, Health Gorilla is going to be well represented. Those are very different conferences, and I think those kinds of conferences create a great opportunity for the team to interact with folks who want to learn more about QHIN, who want to learn more about the services and products that Health Gorilla sells, and just want to talk interoperability, because that's really the point of this, is to improve the access, exchange, and use of health data to improve health across the community.
Well, to our audience and listeners, thanks for joining me on this episode of the Tate Chronicles. I offer a special salute to my guest today, Dr. Stephen Lane, Chief Medical Officer of Health Gorilla. Dr. Lane, thanks for coming aboard today.
My pleasure, Jim.
You can find more information on this show's program page at healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.